Good evening po, Doc.
Are you all in class? Hello?
Yes po, Doc.
Wait lang. Parang wala masyado. Yan. Naririnig nyo ba ako?
Yes po, Doc.
Okay. Okay. Good evening. Sige. Can we start now? Sorry for the delay.
Yes po,
Ngayon lang
Doc.
ako
Okay na.
nakauwi. Okay. Tapos, itong PowerPoint ko sa ibang slides, it's like hindi nag-open yung enlarge one niya picture. So, i-enlarge ko na lang para mas makita ninyo. Okay? Admit ko lang. So, lahat kayo 96 lang ngayon. Ba't kumonti kayo? Okay. So, let's start. So, good evening. Again, I'm Dr. Olive Nasis Ramos. Wait lang. At may nag-join. Okay. So, our topic for tonight is about local anesthesia. Okay. So, you already have discussed about the inhaled anesthesia, spinal anesthesia, regional anesthesia, di ba? And the drugs for general anesthesia from Dr. Corpus. Tama?
Yes po.
So, I will be discussing about local anesthesia. Okay. So, first, we're going to discuss about the anatomy. Can you see it? Anatomy of your neurons. Okay, can you see it?
Yes po, Doc.
Okay. So, this is the neuron. You have the axon of your motor neuron, the axon of sensory neurons. So, and then you have the epineurium, endoneurium, and your perineurium. Okay, the perineurium is the most outside part of your neuron, and then the endoneurium is the inner part. Okay, and then the epineurium is outside the endoneurium. Okay, so as you can see here, the C fibers, A fibers, the afferent fibers, and efferent fibers. So those are the part of your neuron. Okay, next one is okay. Again, to be more specific, so this is the neuron again. You have the axon, the Schwann cells, the node of Renvier, okay, and then the nucleus of your neuron. Okay. Alam na din ninyo to. Okay. We have the, parang ang liit naman. Masyadong maliit ba? Pasensya na, hindi ko alam kung bakit nangyari ito. Pero okay naman sa PowerPoint kanina. So we have the classification of your nerve fibers. So we have the A fibers, B fibers, and your C fibers. Okay? For A fibers, such as A alpha and A beta, they are responsible for your afferent and efferent for muscles and joints, functioning as motor and for proprioception. Okay? And the A delta is for your afferent sensory nerve, functions as for conduction of your pain and touch. This is responsible for fast pain. Okay? Kasi mas malaki ang fiber na A. Okay, and then the B fibers are responsible for your autonomic functions, and while your C fibers are responsible for your autonomic function also, temperature and pain conduction also. What is the difference between your A delta and your C fibers? Diba? Dalawa silang for pain. For A delta, since these fibers are bigger, so mas mabilis yung conduction ng impulses. So it is more responsible for your fast pain conduction. While your C fibers is responsible for your slow pain kasi mas maliliit sila. Okay? Naintindihan? Okay, as you can see, the A fiber so ibig sabihin mas maliit talaga ang C kaysa kay A fibers. Okay. So again, this is the classification of your nerve. So most of the A and B fibers are myelinated, while your C fibers are unmyelinated. Okay? What's the difference between your myelinated and your unmyelinated fiber? So your myelinated, meron kang nodes of Rainville. Okay? So ibig sabihin, you have saltatory movement of your impulse. That's why it is faster. Okay? Yung pag-signal ng impulses mo are faster as compared to your unmyelinated fibers, which has no nodes of Rainville. So, mas mabagal yung pag-conduct niya ng impulses. Yan din yung one explanation why your A fibers are faster than your C fibers for pain conduction. Okay? Naintindihan? So again, as I have explained a while ago, yesterday pa yung lecture natin, your action potential. So you have your phase 1, then phase 2, phase 3, phase 4. So you will have an influx and efflux of your sodium and potassium. And then if you have the exchange of those electrolytes, then you will have an action potential and depolarization will take place. Okay? If you prevent any of the entry of those electrolytes, especially the sodium, then you will have no action potential and you will have no depolarization that would take place. Okay? So now, where do local anesthetics work? So specific receptor theory said that local anesthetics act by binding to specific receptors on the sodium channel. Okay? The action of the drug is direct and is not mediated by some change in the general properties of the cell. A specific receptor site for local anesthetics exists in the sodium channel, which eliminates permeability to sodium channels. Therefore, no impulse conduction. Yun. Ang simple-simple, di ba? So since you have known your action potential, the phases, then if you prevent the permeability of your sodium ions, then you will have no conduction that would take place. Okay? So, local anesthetics produce a transient and reversible loss of sensation or analgesia in a circumscribed region of the body without loss of consciousness. Normally, the process is completely reversible. Kasi nga, di ba, inilipit mo lang yung permeability. So, it will just take time for about 2 hours or 4 hours depending on the drug that you're going to use. Okay? Okay. This is the development of your local anesthetics. Local anesthetics are firstly discovered by Carl Kohler accidentally when he took cocaine orally and noticed numbness in his tongue. Okay? And then Kohler and Gartner reported topical cocaine anesthesia of the eye in animals and human beings. Okay, so cocaine ang unang-unang na-discover as local anesthetic, but they are being used as topical drug only or topical anesthesia, and then followed by your Lidocaine, Tetracaine, Etidocaine, Lidocaine, chlorprocaine, mepivacaine, bupivacaine, prilocaine, articaine, ropivacaine, and the latest drug that was discovered was levobupivacaine. Levobupivacaine is the drug of choice for patients who has cardiac problem. They are not toxic to the heart. That's why they are being used for patients who have cardiac problems. Okay? Ay, bakit naalis? Bakit naalis yung pasensya na, hindi ko alam kung bakit nagkaganito tong kwan ko. So you have the ay, wait lang ha. Ano ako magle-lecture nito? Bakit siya nakakat? Wait lang. Can you just wait for a little bit lang? Mabilis lang naman tong lecture natin. Ayusin ko lang ha.
Yes po, Dok.
Bakit nakat? Tingnan nga natin. Oo, nakat. Stop share. I-end ko muna ha. Pwede ko bang i-end muna tapos paano ko ba to papalitan na lang? I-share ko na lang yung iba kong slide.
Dok, lilipat po kayo ng device?
Hindi. Yung isang na-download ko pa rin na PowerPoint, ganito pa rin. Kasi kinonvert ko tong PowerPoint ko into PDF eh.
Dok, I think you can try stop sharing po. Tapos i-share niyo
And then?
I-share niyo po ulit.
And then share ulit.
Yes po, Dok.
Let's see. Pupuntahan ko yung isang lecture ko. Ito siguro. PDF document daw. Bakit ganyan? Hello? Hello? Hindi ko magawa ng paraan eh. So, we'll just continue with the lecture. Pagpasensyahan na ninyo. I will just give you, di ba you have the copy of my PowerPoint?
Ba't hindi mo pa na-send sa akin?
Okay. I will just send it.
Okay po. Thank you.
Okay? Pero yun. So, can you see my laptop? Can you see it? No. Is it clear?
Medyo malabo po to.
Medyo malabo. Yan. Medyo? Hindi pa rin?
Hindi pa rin po to.
Okay, sige. I will just, you just review it sa PowerPoint na lang. Okay? So you have, for our local anesthetics, we have their parts, 3 parts. So the aromatic portion, which is the amide, or ester. They are characterized as amide or esters through their aromatic portion. And then the intermediate chain, and then the amine group. The amine group is responsible for your hydrophilic characteristics of your local anesthetics, while your aromatic portion is responsible for your lipophilic characteristic. Okay? And then, wait lang. Admit lang natin yung ibang tao. Okay, next one is, we have 2 branches of your local anesthetics, or 2 kinds of your local anesthetics. We have the amides and esters. Diba? May pasensya na talaga. Hindi talaga siya mapa. Ayan, ganyan na talaga. So how about this one? Can you see it? No, pa rin. Malabo. So I will just stop. Just review na lang, ha? So for amides, they are amide link between intermediate chain and aromatic ring. They are heat stable in solution and metabolized in the liver. Okay, they are not associated with allergic reaction, and they are also commonly used as local anesthetic because of their characteristics na hindi sila nagkukos ng, hindi naman, lower ang risk for allergic reaction. Okay? While esters are ester link between amide, chain, and aromatic ring. They are linked easily, and they are the kind of local anesthetics that are broken easily and not stable in the solution. So they are metabolized in plasma through pseudocholinesterases. Okay? And their metabolite are para-aminobenzoic, which causes allergic reaction. So more more na nagkukos ng allergies ang esters. Okay? So, what are those? What are the esters versus the amides? So, esters are tetracaine, procaine, chlorprocaine, cocaine, benzocaine. While amides are lidocaine, mepivacaine, prilocaine, bupivacaine, etidocaine, and dibucaine. Okay? So, paano natin ma-memorize kaagad-agad yung esters versus amides? So, just remember, esters has only one eye. Observe ninyo. Yung tetracaine, procaine, one eye lang. While amides have 2 eyes. Lidocaine, mepivacaine, prilocaine. Okay? O, bonus na ninyo yan. At least, hindi na kayo malilito kay esters versus amides. So, naintindihan, class?
Yes po.
Hello? Medyo malabo ba? Di ba ang dami-dami kasi ng kinds of your esters and your amides. So, at least, mas mabilis ninyong i-memorize. Okay? We have additives for your local Yes, Amines has 2 eye. Esters, 1 eye lang ang nandun sa kanya. Okay? For the additives that you can add to your local anesthetics, we can use epinephrine, opioids, alpha-2 adrenergic agonists, and steroids. Epinephrine, they causes prolongation of your duration of action. Opioids will add the anesthetic and pain relieving effect of your drug. Okay, and then the alpha 2 adrenergic, they can also cause ano na to, relief. And steroids, it will prolong the duration of your action. Okay, the duration of your drug. Okay, the systemic effect of your the systemic absorption of your local anesthetic depends on site of injection, dose, drugs, its intrinsic PK property, and addition of your vasoconstrictive agent, like adding your epinephrine. Epinephrine, again, it will vasoconstrict the area of your site of injection. Hence, the drug will only be concentrated on that area. Hence, the duration of action will be longer. Okay? And also, the absorption depends on the vascularity of your tissues. It determines rate of systemic absorption. So, the greatest absorption to the least absorption is intercostal nerve blocks. So, when you give your local anesthetic through intercostal nerve block, it will be systematic as it will be absorbed readily, and it might cause toxicity. So you should be precautious on giving your intercostal nerve block. And then the least one is the sciatic nerve block. Okay. And then how about the distribution of your local anesthetic? Systemic absorption of local anesthetic is equal to rapid distribution. Okay, once you have given your local anesthetic, it will be absorbed readily and it will be distributed readily, especially for the well perfused organs such as heart, brain. Okay, that's why if you give large doses of your local anesthetic, it might cause toxicity. So it should be you should be precautious on giving large doses. Okay. How about the elimination of your local anesthetics? For amino esters, they are hydrolyzed by plasma cholinesterases, and again, their metabolite is parabens, di ba? Yung sinabi natin, nakwan. Kaya siya nagkukos ng allergies. And then, for aminoamides, they are transformed by hepatic carboxyl esterases and cytochrome P450 enzymes. Now, we will talk about the uses of your local anesthetics. Local anesthetics are easy to use, but they can cause systemic toxicity. Okay. So one use of your local anesthetic is as topical anesthesia. Okay, they are being applied as local anesthetic to mucous membrane, such as for your cocaine, diba? They are being used. The first use of your local anesthetic through topical anesthetic for your eyes, pero now hindi na ginagamit masyado yan. Okay, they are being absorbed readily at your cornea, nasal, or oral mucosa. Okay, uses, they can be used as awake oral nasal intubation, especially for lidocaine. We use lidocaine spray before intubating the patient. And we can also use your lidocaine as superficial surgical for superficial surgical procedure. For excision of your mask, yung malilit lang na mask, you can use lidocaine. Okay, the advantages, it is technically easy, and we just use a minimal equipment. Okay, the disadvantages of which is it has a potential for large doses leading to toxicity, especially if you don't compute your dose. Okay, local anesthetics should be computed according to the weight of your patient. Okay. Okay. The next use of your local anesthetic is IV block or beer block. So we just inject the local anesthetic intravenously for anesthesia of an extremity. They can be used as for surgical procedure on an extremity, especially for ortho patients. Okay, the advantages, it is simple and minimal equipment are needed, and it has a rapid onset. Okay, the disadvantages, the duration of action is limited by the tolerance of tourniquet pain, and it can cause toxicity. Okay, ito yung how we do the beer block. Okay, we just tourniquet the hand, and then we inject the local anesthetic, and then after 5 minutes to 10 minutes, we release the tourniquet. And then after that, the concentration of your local anesthetic will just be here. However, if you give large doses, it may cause toxicity to the patient. Okay? So next use is peripheral nerve block. We inject local anesthetic near the course of a named nerve. Okay? Now, what are the nerves that can be blocked? Okay? We have the brachial plexus, the radial nerve, the ulnar nerve, the every nerves that you can block. Okay? So, ano to? Anong nerve ang nag-innervate ng thumb? Class?
Yes. Yes, sorry.
Uh-huh. Anong nag-innervate ng thumb? No. Wala? Wala na? Okay. Radial nerve. Okay. RT, registered. No. Pwede, median nerve, pero hindi. Most of the one is radial nerve. And then ulnar nerve. Okay? Intindihan? Okay. The use of your peripheral nerve block is for surgical procedures in the distribution of the block nerve. Okay? They are relatively used as small dose to cover large area, and it has rapid onset. Peripheral nerve are being the procedure is guided with ultrasound, with an ultrasound usually. Okay? Kaya mas konti lang yung anesthetic requirement. Okay? The disadvantages, usually complex yung technique kasi nga you use your ultrasound, and it may cause neuropathy. Even if you see the nerve when you do the ultrasound, you still cannot, sometimes they cannot control and they cannot shy away from injuring the nerve. Okay, sometimes lang. Then the next one is, it is being used for central neuralgial blockade or spinal anesthesia. We usually inject the local anesthetic into the CSF, and then after that, the sensory sensation of your patient will be blocked. Okay, especially for spinal anesthesia. Okay, it causes profound anesthesia of lower abdomen and extremities. Okay, however, when we do spinal anesthesia, we only block up to T4. Okay, kasi above the T4, it may cause respiratory arrest or respiratory difficulties. Okay, now, where is T4? What's the dermatomal level of your T4? What is the landmark of your T4? Pala. Class? Nipples. Okay. Correct. Nipples, T4, ang nipples, and then the xiphoid is T7, and then the umbilical cord, and the navel is T10. Okay? At the groin is your L1. Tama, Dr. Elijah, it's T10 for the navel. And then for the groin is your L1. How about this one? The thumb. What's the dermatomal level of your thumb? It's yan. So you cannot forget, it's C6, okay? It looks like 6, C6, okay? C7, C8. Okay, tama. For the thumb, it's C6, and then C7, C8. Okay? Understood? Okay. So what are the advantages of your spinal anesthesia? It is technically easy because you just do lumbar puncture technique. And then it has a higher success rate. And the onset is rapid. Okay? We usually wait until 3 minutes. 3 minutes, the patient, the sensory would be blocked already. Okay? As early as 3 minutes. And however, the disadvantages is it may cause high spinal hypotension due to sympathetic block and post-dural puncture headache, especially if you just kept on withdrawing CSF. It may cause post-dural puncture headache. That's why you have to do it dapat correctly done to prevent those disadvantages or the risk. Okay? Another one is they can be used as epidural anesthesia. Okay? We usually give the local anesthetic through your epidural space at any level of the spinal column. Okay? They can be used for anesthesia and analgesia of your thorax or abdomen or lower extremity surgery. Okay? The advantages, the onset can be controlled and the duration is longer as compared to your spinal anesthesia. Kasi you can top up your spinal anesthesia, your local anesthesia as the procedure is longer, then you can just add up. Okay? They can also be used for post-operative analgesia. Okay? They especially when we add additives such as morphine. Okay? And then, however, the disadvantages of this is they are technically complex. It might cause toxicity also and spinal headache, especially if you puncture the dura and you withdraw a lot of CSF. Okay. Again, now, yeah, the toxicity depends on the amount of free drug in the plasma. This relates to 3 factors. Siyempre, the dose given. That's why you have to compute the dose of each patient according to their weight. Okay? The rate of injection, especially when you give local anesthesia through spinal anesthesia, kasi if you give it as rapid as you can, the block would be higher than T4, then the patient might go to high spinal and you will have bradycardia, hypotension, and the patient might not breathe on himself. Okay? And also the site of injection. Okay? The greater the blood supply to the area injected, the greater the systemic absorption, as what I have told you a while ago. So again, aside from intercostal, the more absorptive area is there, is the interpleural area. Okay, followed by intercostal, and then next, the last one is infiltration. Okay, so for spinal anesthesia and your epidural anesthesia, if you go up higher to the, if you inject your local anesthesia as high as you can, then you might cause toxicity also. That's why you have to compute. It depends on the height then ng pasyente. Okay? So that's why you cannot give your spinal anesthesia or local anesthesia for epidural anesthesia to children as young as below 7 years old because of risk of high spinal. Okay. So, okay, since local anesthetics are wait lang. Yeah. Dose dependent. Okay, so this is one example of your local anesthetic, lidocaine. When your plasma concentration is 1 to 5, you can have your analgesia. If it's already 5 to 10, you can now feel the lightheadedness, tinnitus, numbness of tongue. However, if you go beyond 10 to 45, you will see seizures and consciousness. And then up to 15 to 25, you'll see coma and respiratory arrest. And then if more than 25, then you will have cardiovascular depression. So mamamatay yung pasyente dahil lang sa toxicity. That's why you have to compute. Wait. Okay. So let's go now to the side effects of your local anesthetics. Maliit naman, sorry. For your cardiovascular system, since local anesthetics block sodium channels, thus depress cardiac pacemaker activity and excitability and conduction. So you should be precautious to the patients who have cardiac problem. Okay, with the exception of cocaine, they also depress strength of cardiac contraction and cause an arteriolar dilatation leading to hypotension. And cocaine may cause vasoconstriction and hypertension, also cardiac arrhythmias, while bupivacaine is more cardiotoxic than other local anesthetics. So, ang pinaka-safe na local anesthetic that can be used for cardiac patients are levo, bupivacaine. For the central nervous system, it can cause agitation, auditory changes, difficulty focusing, dizziness, metallic taste, tinnitus, abrupt onset of psychiatric symptoms. And may also cause coma, muscle tremors, seizures, and respiratory arrest. Okay? Yan. Sinabi na natin yung CV effect. Okay? So this is the systemic effect again. Okay? As you go up for the dose, sa dose na 2, up to 2, you will have a normal muna. But as you go beyond the dose, you can have the side effects now until you will have your CVS depression. So what are the treatment for CNS toxicity of local anesthetics? It's usually supportive. Okay? When you see any signs and symptoms of your toxicity, you have to be alert and you just support the patient. So ensure that the airway is patent and the patient is breathing spontaneously. Apply supplemental oxygen. Lay the patient flat. Ensure that the patient has IV access and that intravenous fluid is running. Check the patient's pulse and blood pressure. And if the patient is unconscious, radiothrust may be required to prevent airway obstruction. Okay? Yun. As you can see, it's like your ACLS and BLS. Okay? If the patient is conscious, do your ACLS. If the patient is unconscious, do your BLS. Okay? If the seizure does not rapidly self-resolve, then you can give midazolam at 0.05 to 0.1 milligram per kilogram, lorazepam 0.1 milligram per kilogram, and diazepam 5 to 10 milligram to control seizure activity. If this fails, you can give phenobarbiturate. Okay, and then syempre, you have to secure the airway following the induction of anesthesia with propofol and administration of propofol infusion. Hypoxia should be treated aggressively. So, just give your oxygen and see to it that the patient is well ventilated. Okay? The treatment of local anesthetic induced arrhythmia is Britilyum at 7 milligram per kilogram. However, phenytoin should not be used for seizures because it is also a sodium channel blocker. So it will just aggravate the effect of your local anesthetic. So if still toxicity happens, then you can give intravenous infusion of intralipid 20% emulsion to hasten the return of normal cardiac function. Because this intralipid 20% emulsion may act as the plasma sink to absorb tissue-bound local anesthetic. Parang chelation ang mangyayari dito. Okay? So, usually the dose of your intralipid 20% emulsion is 1.5 to 2 ml per kilogram per bolus and may be repeated 5 minutes after initial bolus if no return of spontaneous circulation. Okay? Pag hindi pa rin nare-revive yung pasyente, you can repeat it. Okay? And then you may start infusion of 0.25 to 1 ml per kilogram per minute until ROS. Okay? And then continued infusion for at least 10 minutes post-ROS. Okay? At maximum dose of 10 ml per kilogram. Okay. However, some literature recommend 20 ml per kilogram or more. Okay, this is the algorithm for your treatment of systemic toxicity of your local anesthetic. When you see a local anesthetic-induced seizure, then stop all the administration of your local anesthetic and then administer oxygen and ensure that the IV is running. Okay. However, if your patient is not ventilating well, then you can opt to intubate the patient. Okay. And then, ay, hindi nyo nakikita yan. Yun lang. Basta yun. The treatment for your local anesthetic toxicity is supportive talaga. If you see that the patient has seizure, then you give your anti-seizure. If the patient is desaturating, then ventilate the patient with oxygen. If you see that the patient is going to hypotension, then give your pressor. Okay? If bradycardic, then give atropine. Okay? Supportive treatment talaga. And then after that, if still not reviving, then you can give your intralipid 20% emulsion while you are still giving your supportive treatment. Okay? Naintindihan, class?
Yes po.
Hello? Naintindihan ba? Medyo maliwanag, medyo malabo. So, local anesthetics are very important, especially for us anesthesiologists, because That's our main agents for spinal and epidural anesthesia. Because for us anesthesiologists, it's easier. It's easier to give local anesthetics through your epidural or spinal procedure, and the block is rapidly seen. And however, we have to see to it that the injection of our local anesthesia is not that fast to prevent any high spinal or total spinal. Sometimes patients who are subject to spinal anesthesia, um, they go to high spinal or total spinal. That's the scariest side effect of spinal anesthesia for us anesthesiologists. Kasi sometimes the patient might go to arrest while you are giving the spinal anesthesia or epidural. Okay? And then what else? May questions pa ba kayo? So again, we have two kinds of your local anesthetics. You have your Amines and your Esters. Okay? Your Amines, is Lidocaine amide? Hello? Ano na? Dalawa yung eye niya. Yes. Diba? If amide, if two eyes, it's amide. If one eye lang, ester. Okay? Which one causes allergic reaction? Amide or esters? Esters. What's esters? Okay. Very good. Dr. Laluan and Dr. Hindi ko nakita yung isa. Wait lang. Okay, Dr. Sam John. Okay. Okay. Yun lang. Ano pa ba? So tomorrow we're going to discuss about pain management, and at 7 p.m.
Yes po, Doc.
Okay, may questions ba? Wala na. Mabilis lang yung local anesthetic class. Kasi konti lang naman siya talaga. Just memorize the esters and amides, their toxicity, and treatment, yung mga ganun. Okay? As long as you know the BLS, ACLS, then you will be guided. Okay. Okay na. Okay. Good night. Thank you. Thank you. Okay. Thank you. Bye. Thank you. End ko na. Salamat.